last, I invite Dr. Anuradha VK for her keynote address on immunosuppressives in uveitis. After hearing all infectious uveitis, she will give a talk on immunosuppressives in uveitis.
Thank you, Dr. Isha, Dr. Rajsri, Dr. Srini, and the rest of the organizing team of Drishti 2023 for having me here to talk on immunosuppressives in uveitis. It's very ironic, no, after discussing a lot of infections. So, we all know that in non-infectious uveitis, steroids are still the first line of treatment, because they act very quickly and they work across a spectrum of disorders, okay? But we also know that, steroids often, and they are not very good at controlling inflammation adequately. And you also got to remember that the patient who comes to see you with uveitis is not looking just to get rid of the disease. They want to be free of the drug as well. So this term called remission, where the patient has no uveitis and is drug-free for 3 months, that is the goal. I think that should be the goal. So which patients need immunosuppression? So it could depend on the nature of the uveitis. And you have the first set of indications, which I would call the primary indication for a primary immunosuppression. So by that, what you mean is, as soon as you're sure of your diagnosis, you're sure this patient has this particular entity, you're going to start them on immunosuppression along with high-dose oral steroids. And right at the top of the list is Behçet's disease, followed by sympathetic ophthalmia, and necrotizing scleritis with or without PUK in granulomatosis polyangiitis or rheumatoid arthritis. I will also include selected cases of immune-mediated serpiginous choroiditis and selected cases of VKH, which we can open up for discussion later. So coming to the next set, it's, you have a recurrent inflammation, as in the case of HLA-B27 uveitis, or a chronic uveitis associated with JIA, you should go for early immunosuppression. Our next set of indications come from response to treatment, or I should say lack of response to treatment. And whenever you are moving from steroids to immunosuppression, for that matter, anytime you are escalating dose or changing medication in uveitis, there are 3 things you need to rule out. One is non-compliance, non-adherence to treatment, infection, and masquerade. So what do you mean by lack of response to steroid? So if a patient has been on high-dose steroid for about 4 weeks, or in a dose more than 30 mg is not adequate to control inflammation, as in this case with a bilateral retinal vasculitis, you need to add IMS, and you can see the improvement after adding methotrexate. The second indication is, okay, you started high-dose steroids, started at 60, patient is doing well, you managed to taper it down to 20, patient has a reactivation, you discuss, you hiked it back to 40, you again taper it to 15, you have another reactivation. So if you need more than 7.5 milligrams of steroid to control inflammation for more than 3 months, once again you need to add immunosuppressive to try either to take them off the steroids completely, which is the goal, and I think it's one of the important steps for inducing remission, or to keep it at 7.5 milligram or below, because that's the dose that's considered to be safe for intermediate use. But as you can see from this article, the cumulative dose of prednisolone also matters, okay? So you want to try and take them off steroids if possible. I don't think I need to go into details about side effects and intolerance. I just want to tell you, intolerance is what the patient feels subjectively. It's very important to take into account, because that's one of the causes for non-compliance. And generally, if I look at my patients who are on high-dose steroids are generally unhappy patients. The moment you manage to reduce them to below 10 or put them on just IMS alone, they feel much better. So IMS is much better tolerated than steroids. So once you have decided that a particular condition patient needs immunosuppression, the decision to start the immunosuppressive and, the kind of immunosuppressive you need to start should be the result of a open discussion with the patient as well as with the family. And you need to explain to them why you need, you need to start them on IMS, the duration of treatment, because it's very long, it's around about 2 to 3 years, okay? You also need to assess the fitness for immunosuppression and advise them regarding very strict follow-up and the do's and don'ts. So the fitness has 2 components. The first part is a history, where you want to rule out past history of tuberculosis, any ongoing active systemic infection or any recent infections. You also want to rule out any major systemic illnesses like, liver problem, kidney problem, heart problem, any history of malignancy. And if they are in the child bearing group, you want to rule out they're pregnant, or a female patient, you want to rule out pregnancy and whether they are breastfeeding. And you also need to ask them whether they will be willing to postpone having another child for the duration of treatment, so these are the things you need to roughly go through. So for starting non-alkylating antimetabolites, I do complete blood count, SCOT, SCPT, creatinine, Manto, chest X-ray, TriDot, which is HIV, HBsAg, HCV, BP and sugar. And in the rare case where I start cyclophosphamide, I will do urine for RBC as well. This is a list of the most commonly used conventional and immunosuppressives in uveitis. I'm not going to go into details. You can read them from any standard textbook. I just want to tell that if you ask the one medicine I go to, it is methotrexate. So once you start them on these medication, they are followed up after 2 weeks. You repeat complete blood count, SCOT, SCVT, creatinine, BP and blood sugar. And then they're seen after 1 month, and then 1.5 months, 2 months, until they are stabilized and I'm sure that they're responding to the immunosuppression, and thereafter for the rest of the course of treatment, they will be seen every 3 months, along with the lab workup. So a few things I want to tell you about using immunosuppression for controlling uveitis. Most of the conventional non-alkylating antimetabolites, they work very slowly. They take 2 to 3 months to act. So very important that you cover with adequate steroids during that period. So the dose of steroid will depend on how severe the inflammation is, and you have to taper the steroid slowly. Otherwise, you will get a reactivation. So you can start with a smaller dose of IMS and escalate the dose if needed. If one immunosuppressive is not working, it's best to switch to another immunosuppression. So like I said, the goal is to go for a steroid-free remission and thereafter hold non-alkylating agents for 2 years. And if it's an alkylating agent, you have to hold them for 1 year. So it's the time is of essence to induce remission. So although immunosuppressives, they really have made a difference in the management. As you can see from this data here, okay, this is the 1 year steroid sparing success of the commonly used conventional immunosuppressives. At best, it's around 60%, okay? So that means about 40 to 45% of the patients don't achieve a control with IMS and 10 milligram or more of steroids. That's what it means. And this is taken from the site study. So you have the next class of immunosuppressives named biologicals. Once again, I'm not going to go into theory. You might know that the adalimumab injection is probably the most popular biologic that's available now. It's a TNF alpha inhibitor. It's given subcutaneously every 1 to 2 weeks. The only problem with the injection is it's expensive. Also want to mention rituximab, which is very useful in scleritis, especially in granulomatosis, polyangiitis, orbital inflammation, and PUK. So the most common indications for switching to biologicals is Behçet's disease, JI, and seronegative spondyloarthropathies, and usually You'll find that rheumatologists use adalimumab along with methotrexate. So in addition to the side effects of conventional immunosuppressives, you need to watch out for reactivation of tuberculosis, a worsening of multiple sclerosis, and congestive heart failure with the TNF-alpha inhibitors. I just want to speak briefly on tofacitinib. It's a Janus kinase inhibitor and is showing very promising results in refractory uveitis and scleritis. Even those which have failed to respond to adalimumab have personal experience as well. Very affordable, and it's available in the tablet form. Its dose is 5 to 10 milligrams per day. So in addition to the risk of opportunist infection, some of the studies says that there's an increased risk of pulmonary embolism. Not all studies, not all reviews agree with it, and a slightly increased risk of malignancy. But this one, probably I think will replace adalimumab. That's my feeling. So I just want to end with this this patient. This is one of my patients who's been following up for the past 10 years. He was already diagnosed Behçet's, when he first came in 2013. Left eye had 624 vision, right eye had 6 vision. He failed to respond to methotrexate max dose. Azathioprine he couldn't tolerate. Put him on cyclophosphamide, and he developed a subretinal lesion. I was worried about whether it's TB, so I stopped cyclophosphamide. He was still on 30 mg oral steroids, advised with biopsy. Overnight, his vision went from 6/6 to 2/60. After that, he was referred to a rheumatologist. He was put on infliximab, adalimumab, had a very stormy course. He was in ICU a couple of occasions. And after they stabilized, he is on triple immunosuppression, azathioprine, cyclosporin, and Visolon. And this is his right eye today. I saw him this week as well. That's 6/9 vision in that eye. And every time I look at him, I tell him, I think you're a miracle that would not have been possible without use of immunosuppression and biologicals. Thank you very much, and this is the suggested reading.
Thank you, ma'am, for your talk. Any questions for madam from the audience? Okay. I think no questions.